Good evening, everyone. My name is Melanie Ionase, and I am the Physician Relations Specialist here at Rothman. Tonight's webinar is with Dr. Michael Molter. Office location is in Washington Township. Topic that he'll be covering this evening is what's this pain in my neck? This will be an insightful virtual discussion focused on addressing neck and shoulder pain. The aim is to gain a comprehensive understanding of the pain and explore various non-surgical treatment options. Dr. Molter brings his wealth of expertise to this session, offering insights into the diverse range of treatment options available. This also aims to equip attendees with a nuanced understanding of the causes, symptoms, and tailored strategies for effectively addressing neck and shoulder pain. We hope you gain valuable knowledge from our seasoned expert and empower yourself with informed choices for optimal health. Just a few quick notes. At the bottom of your screen, you will see a Q&A icon where you can enter any questions you may have throughout the presentation. We will have time at the end to answer as many as we can get to. Also in the chat box, I will show Rothman's phone number if you would like to make an appointment, as well as my email for any assistance you may need. This webinar is being recorded, and you will all be emailed it in about 7 to 10 days. So without further delay, I pass this off to Dr. Molter. Dr. Molter, thank you and welcome, and thank you for your time this evening.
Oh, thank you. I don't know what to say after the introduction. You must clearly have the wrong physician profile there. But no, we can go ahead and we'll get started here. Basically, let me get my, how do I change my, now this is, why are my slides not changing? Oh, hold on. Just let me make sure I can do what I need to do. There we go. Okay. So basically the goals of this lecture are to note the various causes as far as neck and shoulder blade pain are concerned. Really what I want to bring about the patients is that, the exam, particularly in these diagnoses, is a key to kind of pointing to where we're going with this. And you can come in with various pictures and MRIs and things, and it's not always the answer. That's really only part of what we're looking at as far as figuring out where these pains are coming from. And, we obviously, this sounds silly to say, but we have to know where it's coming from because every treatment is different for this. So if you start treating something that's not the problem, then we're just delaying you getting better at this point. So that's why I wanted to address this. And the pain in the neck is not my kids. I actually like them, but I always enjoy saying that is because I normally get the look from the husband or wife when I'm doing this talk, and they're like, this is my pain in the neck, or vice versa there. But I try to keep these lectures as informal as possible, and I hope we can generate some questions and answers more so for what you may be wondering about, what's bothering you at this point. So 2 things before we start. So one other reason why I do this lecture is a lot of times patients will come in and I can almost guess what set of x-rays they had when I see what they're here for, whether it's their back of their neck or their shoulder blade. They invariably come in with x-rays of these are is your thoracic spine. So, and I will tell you that, and we'll get into it more, that is the least common cause of pain in that area is from your middle back there. The other thing I would like to say is, I don't know how many patients that are listening that I already see or come to Rothman, but I always like to thank all of you for supporting us and particularly myself as a practice. I've been at Rothman now 11 years, and I never take it for granted as far as this goes. Taking care of patients is it's a privilege. It's not a right. And there are other places that patients can go for their care. So I appreciate that you all kind of stuck by us here through thick and thin, particularly after the pandemic. We're still trying, everybody's still trying to get back on their feet 4 years later. So, I'd like to just throw that out to everyone there. So determining the cause. So the first thing we have to do is figure out where this is coming from. So obviously, since all treatments vary, and not all of them have to be orthopedic related. So not only do we have to get a complete history from the individual, but also evaluate for the orthopedic and non-orthopedic causes. including a cardiac evaluation. So, it's not as simple as saying, well, you have a muscle strain and that's it. If there's cardiac symptoms that we're missing, that's obviously a much bigger fish that we're dealing with than someone that just comes in with a muscle issue. So the physician, when they're examining you, has to not only take all that into account in asking you the right questions, but also in the overall exam of the patient themselves. So, when we look at these, the overlap of these, we're going to address each of these individually. Some are more detailed than others, but when we're looking at causes of neck and shoulder blade pain, they can be broken down typically into a couple different facets, whether it's from the neck, which is the cervical spine, the middle back, or the thoracic spine, which we just talked about, the shoulder itself. Some folks just have muscle pain, which is the myofascial pain, and some are caused from other issues like the cardiac, and there'll be other organs that can refer pain to that shoulder blade area. So we want to keep all those things in line and in our mind, particularly when we're examining a patient. Just because you're in an orthopedic office doesn't mean you necessarily have an orthopedic problem. And we're all physicians, so we have to be able to kind of figure out where things are actually coming from as far as that is concerned. Again, I have a couple pictures just showing the overlap of these structures. Particularly in this image here, you can see the bulk of the shoulder is in this area, but the neck muscles attach up here and go down into here, and then you have your the thoracic area where the muscles kind of go across. Similar pictures here. I overlap these slides on purpose just because that's what we're dealing with. And a lot of times I will see somebody, their exam will say, well, maybe it's a little shoulder, maybe it's a little neck. And we end up treating both and kind of see how things sort out, because it's not always a clear-cut picture. A lot of times having an issue in one area causes the muscles in another area to give you issues, and then end up with something that's being caused by multiple sources. So we really want to keep that in mind as far as that's concerned. So we'll get into the causes here at this point. The first is nerves that become trapped. And what I mean by this is either by injury or swelling or inflammation, there are compression of the nerves that travel throughout the shoulder area. Similar to carpal tunnel, but basically in the shoulder region. And I highlight two here with the arrows that we have. The one is what we call your suprascapular nerve. And what that means is basically that's the nerve that runs around your shoulder blade. It runs in the bottom part, and then above that spine of your scapula, that bone you feel running across there. And that muscle basically goes, or that nerve, I should say, goes to those two muscles in that area. And it will not only cause pain in that area, but it can cause weakness in the muscle as well as loss of some muscle in that shoulder blade. So again, the exam becomes part of this, particularly when you're looking to see, well, is there weakness here? You don't have pain down the arm, but if you have weakness in that arm and those specific muscles to that nerve, then you kind of have to look at, is this what's causing our issue? A lot of times, particularly with the suprascapular nerve, what happens is patients have an injury to the cartilage in their shoulder. They end up developing a cyst, and that compresses that nerve as it kind of runs through here. And that affects the muscles that are involved. Treatment for that is usually conservative unless the patient has something significantly pushing on that nerve where they end up needing to have a surgical intervention for that. So that's the top nerve. The other nerve that we look at is the suprascapular, or not suprascapular, I'm sorry, the axillary nerve. The axillary nerve basically goes to the muscle on the outer part of your arm, and injury to that a lot of times occurs with trauma to the shoulder, fractures in that area, as well as it can kind of get pinched in this little area down in here where it comes out of. Most patients with this will have some numbness or tingling right on the outer part of their arm, but also pain into the back of the shoulder and difficulty lifting the arm up above their head. Treatment for this is usually conservative. Obviously, if there's a trauma involved, then that has to be addressed. But really, the only thing that we can do to help lessen the weakness once you eliminate the cause of it is with therapy and other conservative care as far as that goes. So these are the two specific ones. There are other nerves that can get trapped and cause some shoulder syndromes here and there, but really when we're talking about an orthopedic standpoint, we kind of focus on this area itself. So the next area is looking at the shoulder joint specifically. And essentially each one of these topics here could be their own lecture. And particularly with the shoulder, there are so many significant areas there, little muscles, little nerves, cysts, tears in the muscle, things to that effect that can cause shoulder issues and refer pain into that shoulder blade area and sometimes up into the neck area as well. The basic ones are the tendonitis, where you just have some inflammation in the muscle because it's being pinched, or as we had mentioned, you can get cysts within the shoulder. The shoulder dyskinesia is when the muscles that surround that shoulder don't allow it to move in its normal motion, and it tends to get inflamed that way as well. When we look at where these areas refer pain, a lot of times it's to the outer part of the arm, in this area here, also in the back part and up into the back part of the neck and towards the front as well. One thing that I would emphasize with this picture is that most of the time, if you have pain that's going past the elbow, it's not usually shoulder related. Where you can see in these photos or diagrams, there is not anything that illustrates pain that's radiating below the elbow itself. So these tend to stay from the elbow up and in the back part of the shoulder there. What we're looking for, and shoulder is a big part of the exam itself. And what I mean by that is whether you're looking for a rotator cuff injury or a cartilage tear in someone's shoulder, there are tests that are done to try to evaluate that. And I'm not going to go into all those here, but it's a big part of that shoulder exam. Because if you have something that's irritating a tendon, a lot of times it'll be tender just to kind of pushing in that area. Whereas if it's a nerve, you can't usually push on a nerve and cause pain. Like you can't push on someone's sciatic nerve and cause them discomfort down the leg. It just doesn't work that way. So you look at these tests. You look at, well, is there weakness in certain muscles and not certain muscles there? The motion of someone's arm, whether they're able to get it above their head, behind their back, things like that, all come into play. But unless there has been a significant trauma, usually these are treated conservatively with physical therapy, anti-inflammatories, and other medications to try to help lessen the pain or discomfort. Other options include injections into the shoulder itself, whether it's done in the office, just without ultrasound or with ultrasound. And a lot of times those are, obviously we're trying to help with the pain, so they're a diagnostic injection and a therapeutic injection to tell us, well, is this where this is coming from? Additional options, if you don't get better with that, are ultrasounds, MRIs where they inject dye into your shoulder. Those are usually done more to help with looking for instability in the shoulder or cysts within the shoulder that are causing nerve compression. Again, just trying to touch on this a little bit. Each one of those diagnoses with the shoulder could come with their own lecture there. Next thing that can cause some pain in this area is what we call the cervical facets. And what those are is pretty much, facet joints are a hot topic, whether we're talking about lower back or neck in this case. And what those joints are is, the way I describe them to patients is they're joints just like your knee, your shoulder, your elbow, except nobody talks about them except spine doctors. But what they are is you have one of these joints on each side of every vertebrae from your neck down to your lower back, and they help provide stability in your spine. And basically, these will cause primarily pain localized in these areas. It will not usually cause pain going down an arm or down a leg unless there's something associated with it, like a cyst or something that's pushing on the nerve. They tend to kind of stay around the spine area and the muscles in that area. And the diagram here basically shows how widespread you can get this referral of pain and the overlap of these joints as far as that's concerned. The other reason that we see a lot of this is, and we'll talk about it, is when people have a whiplash injury, these are often affected. And when you get pain with this, it's usually when you're bending your neck backwards. And the reason is because when you look at the anatomy of this, the joints sit in the back part of the vertebrae. So when you bend your neck backwards, you are compressing those joints. So that tends to aggravate symptoms that are consistent with those joints for that reason. Just like if you have a disc problem in your neck, a lot of times bending forward tends to flare up a lot of those symptoms because the disc sits up in this area here. So when you bend forward, you're putting pressure on that. When you bend backward, you're putting pressure in the back part of the vertebrae as well. So whiplash, you can imagine if you're in a car accident and you have a whiplash-based injury, basically you have a significant bending forward and then a rapid bending backward, and that will tend to generate discomfort in that area. Not always, but a lot of times when folks come in from after an accident, this is usually what we're looking at as far as a mechanism of injury associated with these joints there. The treatment for these, at least initially, is all conservative, whether it's therapy or medication, whether muscle relaxants, anti-inflammatories. There's nothing surgical to do for these joints. Injections can be done as well, which we'll get into, as well as procedures beyond the injections, which include burning of the nerves that go to those joints. Physical therapy is the only preventative treatment we do. When I sit down with a patient and talk to them about the 4 ways we can manage most things that come into the office that I see, it's usually either therapy, medicine, injections, or surgery. And most of the time, nobody's looking for surgery, and injections are not usually our first line of treatment. What I tell them about therapy is, again, it's the only preventative part that we do, whether we're talking about these joints, whether we're talking about the shoulder, or if someone has bad arthritis in their neck. Those are all things that respond to physical therapy. You can use medicines, you can use injections, and they will help with the pain you have, but they don't prevent things down the road. If you came into the office, were having no pain and said, I'd like to get a shot, I would tell you that's not indicated because they don't prevent things. They only help with the pain you're having then. So that's why we do the therapy, because we need to get you better down the long road. And the way to do that is to strengthen that area, take pressure off of the joints, and alleviate the inflammation in that region. Usually therapy follows a specific treatment plan. Now, obviously it's different for knees, shoulder, elbow, neck, lower back, but what is usually done is the first step is usually to reduce someone's pain. The next is to improve the motion of that body part, and then work on the strengthening part. Because if you try to work on strengthening or improving someone's motion before you lessen their pain, you're not going to get the most out of that strengthening part, because you're going to still have a limitation because of pain or motion that you're lacking there. And I've had times where I will send patients to therapy, they'll come back and say, all we've been doing is this and this and not really strengthening in anything. And I try to explain to them that that normally is the way we do things, because that's what's going to help you get the most out of strengthening, is to lessen the pain and improve the motion that you're having there. Injections for these joints. So again, injections are not ever the first line of treatment. They're usually done under x-ray, and they serve 2 purposes. One is obviously to try to help with the pain or a therapeutic cause. Diagnostically, it tells us, well, is your pain coming from there? The reason we do these under x-rays, you can't just put a needle in someone's neck and say you're in the right spot, nor would you want me to do that there. So when we look at this, what is done now is a little different than what used to be done. What used to be done was we would put a needle back there and do an injection with a little bit of lidocaine or numbing agent and a steroid medicine. And they would be an injection just like you would get your knee or your shoulder injected. And then we would see how you do. But what we found was, we were repeating these injections over and over, and patients would get relief, but it wasn't really giving them long-term effects. So then what we've started to do now is what's called a medial branch block. And what a medial branch block is the medial branches are the actual nerves that come out here and go down into these joints. And we block those nerves to try to help with the pain you're having. The injection there is not a steroid-based injection. It is basically a numbing agent. And what we're trying to do is lessen the pain coming from that nerve. Now, when we do the injections, what is done is the nerves that come to these joints, and this is way more than most of you would want to know, is it comes from above and below. So you have to block the nerve above and below where it comes from to get the full coverage that you're looking for there. The procedure itself takes about 10 or 15 minutes to do, depending on how many levels, or if you're doing both sides of this procedure. These are done in the office, again, under x-ray, and most of the time patients, if you're in the office, we're not sedating you anyway, as far as that's concerned. And the relief should be fairly quick because it's a numbing agent and you don't have to wait for your body to break down the steroid there. And a number of things can happen. One is we can do this and you will get long-term relief and it won't come back and we'll be all good. The other will be is if we do it and you get no relief, then normally we will not repeat it because it's a pretty diagnostic injection. It's not like an epidural where sometimes it takes more than one to get you that relief. The other is if we do this and it comes back, then we repeat it. And if we repeat it and it comes back, the next step is not to do a third injection, because if we try to order a third injection, it won't be covered. The next step is normally what's called a radiofrequency ablation, and not everybody ends up needing that, which is why when I first see patients, we don't get into that full discussion, because there are some folks that just have the nerve blocks and it goes away there. And this is a number one question I get these days is, I had a friend, they had their nerves burned. Am I a candidate for that? And, it's a process to get to that point. You have to prove that that's where the pain is coming from in order to do that procedure, because you're not going to put someone through that if they didn't get relief from the other procedures itself there. So what is the ablation? And basically it's called RFA for short. It's basically the process is you've had 2 trials of those nerve blocks done, and so it came back. So then we set you up for the ablation. Now, the ablation is a couple things I make known to patients with that. The first is an ablation does not work as quick as the nerve blocks that we did. And that's a number of different reasons. One is it's a procedure that can generate a little bit of inflammation as it is, so that does take some time to resolve. So always make patients aware that this is going to take longer, because otherwise they will call me a day after and say, well, I had the nerve blocks, they worked right away, but this ablation didn't do anything. So it can take up to 6 to 8 weeks to get full amount of relief from that. But why we started doing these was because you can get much longer term relief without putting steroids over and over in the joint. The hope for relief is 3 months to a year. You can repeat this several months afterwards if the pain comes back, because the truth is the nerves can regenerate. Does that happen in everybody? No. And there's really no way to predict that until we actually do it and see how you do. Now, I will bore you with details, but over the last couple of years, as far as approval for repeating an ablation, it usually is they won't make you go back through the nerve blocks if you've been within a number of years from your ablation and you're having the same symptoms. Now, that's subject to change at any time, depending on the whim of the insurances there. But it used to be no matter how far out you were from those nerve blocks, you had to, or the ablation, you had to go back through the nerve blocks then. So another cause of this would be what we call thoracic radiculitis. And basically what that is irritation in the nerves as they come out of your middle back or your thoracic spine. This is the least common of the disc herniations that we get compared to neck and lower back. Most of the time, folks don't know they have this until they become symptomatic. When we talk about these symptoms associated with this, it is usually they will get pain that comes from the back radiating across the front of the chest. It doesn't always have to, but that's normally what will happen if you have something pushing on that nerve in that area. And why that is because those nerves, that's how they run there. The other thing that happens a lot in this area is you have a lot of organs that sit there. The heart can refer pain there. Other abdominal organs can refer pain into those areas, which I'll get into. So we have to, a lot of times, this is not our first diagnosis there. And treatment for this is usually conservative. Usually the same as a pinched nerve in your back or your neck, where we start with therapy, medications. Sometimes injections are done there as well. but again, mainly conservative as far as that goes. When we look at this, basically, your thoracic spine basically starts up at the top and kind of goes down right to just around where your belly button is there, and these areas are associated with where the ribs basically lie as far as that goes. And when we look at the ribs here, the nerves in the middle back follow your ribs and come around the front. Whereas if you have a pinched nerve in your lower back, it goes leg, or a pinched nerve in your neck, it goes down your arm. These nerves tend to follow your ribs as far as that's concerned. As far as that goes, again, treatment is usually conservative as far as that's treatment of the thoracic spine nerves are concerned. Again, not everybody has the pain that's radiating around the front, but it isn't, it is a possibility as far as a symptom is concerned. But again, not that common. Typically, though statistics change all the time, these occur in much older females, or unless you've had a trauma that can cause injury to that nerve as far as that goes. So the most common cause that causes these issues is basically a pinched nerve in your neck, or a disc herniation in your neck that's causing some of these symptoms. Now, whether it's a disc herniation or wearing down of the disc that's causing narrowing around the nerves, this tends to be the most common cause of this. And when I talk to patients about this, and they'll come in, and like I said, a lot of times they'll come in and have those x-rays of their thoracic spine, I say to them, you know, even though this pain is between your shoulder blades and that's below your neck, those muscles in your shoulder blade area get their nerves from your neck. So even though that's where they're sitting, the most likely cause of this is coming from there, as far as that goes. A lot of times patients will come in, they'll talk about tightness in their neck, pain going into the shoulder blade or down the arm, numbness down the arm and into the hand. Again, once you start getting past that elbow, it kind of eliminates the shoulder as a cause of this. Weakness such as dropping items. You can have weakness lifting your arm overhead with this if it involves the nerves that go to those muscles, as well as pain that is waking them up at night in that area. Now, a little bit of boring stuff here is when we look at the neck, there are 7 nerves in the neck, or 7 vertebrae that we look at, with 8 nerve roots. The high percentage of these muscles in the area that we're looking at, these nerves go to them as far as that concerned. And the nerve irritation, again, can come from a disc that's pushing on the nerve. You can have wearing down of the disc that you formed a bone spur in that area that's causing nerve irritation. And those are the most common reasons to have that. Sometimes if you have an injury, you can stretch these nerves as they come out of your neck as well and not have anything that's pushing on them. Usually what we call your C5, C6, C7 are the most common levels that we're looking at as far as these go. When we talk about specifically muscles in the shoulder blade area, the muscles around the shoulder blade, what we call your supraspinatus and infraspinatus, or above and below that spine of your shoulder blade, the muscle in the outer part of your deltoid there, and the muscles particularly between the shoulder blade, those rhomboids and your teres muscles, all get nerves from their muscles, I should say, get nerves from your neck. So they can all contribute to that. And a lot of times that's the only symptoms folks have, particularly what we call your C7 nerve. It's notoriously causes issues within the shoulder blade itself. Now, the interesting thing is, and this is not an all-inclusive list of muscles that get these nerves. So if you're suspecting this, you may see some weakness in other muscles down further in the arm that get that C6 nerve. And that could tell you, hey, this is coming from the neck because we're getting muscle weakness, not only around that shoulder blade, but down the arm as well. So we keep an eye out as far as, you know, what the actual exam is showing us there. Speaking of exam, a lot of times we'll see patients, they have limited movement of their neck and arms because with spasms in the neck, it'll oftentimes limit you turning to one direction or the other. Or I'll sit and watch a patient when they're looking at me and they have to get up to sit and turn because their head doesn't turn as far as it should. Weakness in the muscles of the arm, as I just said, you can see that, and that could be associated with the same nerves that are going back to the shoulder blade area. loss of feeling in the arm, loss of muscle in the arms or hands as well. There are certain tests we do where we have patients kind of turn their head and look up, and we see if that generates pain down the arm, and that can certainly suggest a nerve cause to these symptoms. Now, nerves themselves are funny. What I mean by that is this, is they act their own way. They cause different things in different folks, and they recover in their own way. And basically, there's nothing we can do about it. Basically, what we have to try to do is lessen the symptoms that the nerves are causing from that area. And whether it's the pain down the arm, pain in the back of the shoulder blade, we're basically treating things. The nerve is going to generate its own recovery at its own rate, whether you have a shot, whether we put you on medicine, whether we put you in therapy. The recovery is based on its own. So we just have to kind of sit back and watch, but try to treat what's going on. So usually when a patient comes into our office, we will get a baseline x-rays of their neck unless they've already had additional pictures before that. Usually when we get those x-rays, it's 4 views of the neck. Basically, I'll show you those, one from the front and several from the side, one where we have you bending forward, one where we have you backward and just straight there. MRIs, as far as this is concerned, are not usually ordered unless there are reasons to do that, whether you've already had a full course of conservative care with therapy and such that we need to do the MRI. If you have red flags on your exam or history, whether it's weakness on your exam, a history of cancer, difficulty walking, balance issues, any of those things are signs that, you know, we probably need to do a little bit more than the basic x-ray as far as that's concerned. These x-rays, basically, we get a view of you from the front to make sure you don't have a significant curve in your neck. This is just a view straight from the side here. Now, when we look at what we talk about, degenerative stuff in someone's neck, basically that's narrowing in the spaces here. When you see that narrowing, again, that suggests that the disc is wearing down, but an MRI really is the picture that gives you that as far as that goes. But when those bones get closer together, in this area here, what happens is you get increased blood flow to that area. And when you get increased blood flow to the area where there's bone, you get more bone formation, and that subsequently will cause narrowing around where the nerves come out. And then that leads us to having these symptoms that folks have. The reason we do the pictures where we have you bend forward and backward is to make sure your alignment is good and there's no what we call instability or movement of the vertebrae in your neck itself. As far as an MRI goes, when we look at an MRI, basically, we're looking at, as far as a disc herniation goes, a disc herniation is basically the inner part of the disc has pushed itself into this space where your nerves and spinal cord are traveling through, kind of in this area here. Couple things about that. So the best description, which seems to hold the test of time, is it's kind of like a jelly donut in that the inner part of the jelly is kind of come out from that disc. And that's basically what's pushing in that area. Now, when it's sitting in this space, what happens is, and this is why 90% of disc herniations get better without surgery, and we treat these conservatively, is because your body sees that as a foreign object, kind of like if you have a splinter. So what it will do is it will try to shrink that disc on its own. So that's another reason why we try to manage these symptoms conservatively, is because of that. You know, if we can, and patients have a hard time believing me when I tell them that when they come in because of the severity of pain they're in, but that most of the time that's what happens. Now, obviously there's 10% or more that have surgery, but a lot of times it ends up being treated conservatively with that. I bring these pictures up because we don't treat images. I have being in medicine for almost 30 years at this point. I've come up with all kinds of sayings, but one that I like is we don't treat the picture, we treat the patient. First of all, this patient is most likely not walking into my office because they have a fracture into their spinal canal. But if you look at this patient, they have significant, this is a ligament in front of their neck and it's all calcified, but they may not have any pain at all. You know, we don't treat images because I have patients that come in and have terrible looking x-rays and have no symptoms. And then we'll have a patient that comes in and has an x-ray shows a little bit, or an MRI that shows a little bit, and they have a ton of symptoms. So the MRI really is just designed to be an adjunct to your exam. So I always want to tell patients that, because they'll come in and say, well, my MRI says I have a disc bulge. And I'll be like, it does, but that doesn't mean that's necessarily what's bothering you. So we have to keep all those things in mind there. So say you come in, we evaluate you, we feel you may have a nerve issue, you have an EMG or an MRI, doesn't show any nerve irritation there, or it doesn't show, I should say, nerve compression. And why that is for whatever reason, but you're still getting the nerve symptoms. So again, you can have a nerve that's irritated in your neck, causing you stuff in your shoulder blade and down your arm, but you don't necessarily have to have a disc herniation or a pinched nerve. A lot of times it could just be inflammation, but an MRI doesn't show or gauge inflammation as far as a nerve is concerned. Basically, that's done through a test called an EMG test. And an EMG test is really the only test that demonstrates nerve function. Especially when we're dealing with symptoms in this area, it can help you to differentiate, hey, is this coming from their neck? Did they have a pinched nerve in the back of their shoulder blade that's causing these symptoms? But it is often a test that's ordered to kind of assess not only where the nerve is being pinched or injured, but also what kind of recovery we can expect with that. Now, it's not the funnest test. It's more irritating than anything else. And I've had it about 20 times. That's how you practice it in training, is on each other. Not saying it's comfortable, but it does tend to yield us quite a bit of information as far as that goes. Treatment options for this are the same as anything else for a lot of this, I should say, of what we spoke of. The first is physical therapy. That's really the only thing that we treat long-term with this. Medications and injections are designed to help pain that you have. They don't prevent things. Injections are not usually our first first treatment, unless you're not going to tolerate therapy there. The injections in general, basically what we're talking about is an epidural injection. There is nothing we do that changes your anatomy. There's no medicine, there's no therapy, there's no injection that changes the anatomy that's going on. And, we talk about different types of injection based on the circumstances themselves, whether patients have had surgeries. There, they may need a different injection. It's called a transforaminal injection. The other thing that they're not usually our first line of treatment is, if you're on a blood thinner, you have to come off of that. So then that could put you at risk of other issues outside of your neck. And the last thing we want to do is create other issues, whether it's something being off your blood thinner, or if you have a patient that's an uncontrolled diabetic, blood sugar certainly can mess with those sugars and cause you issues as well. So the last thing we want to do is get a letter or a call from your doctor saying, hey, so-and-so had uncontrolled sugar, gave them an injection, now they're in the hospital with their sugar was 600. That's not what we want to do. So the injection we typically do is what's called an interlaminar injection. And for simple facts, basically the lamina is the bone in the back of the vertebrae. So you're going between the bones in the back of the vertebrae itself there. Again, not usually done unless the patient has failed conservative care. These type of injections are normally done to help pain down the arm or nerve radiating pain down into the back of the shoulder area. They're not usually done just to help neck pain. Now, if you have someone that's been through multiple medicines, multiple therapies, and things to that effect, and are still having pain back there, and it's just in their neck, will we consider an epidural? Yes, but it's not ever the first line of treatment, particularly for that. Are done under X-ray. Simple discussion I have with patients is, it's a visit just like you came in to a regular patient visit. You check in out front instead of coming back to the room where we examine you normally. We take you where we have the X-ray, put you under the X-ray, give you some numbing medicine, and do the actual injection itself. Takes some time to start working. Most of these now are done in the office, not sedated as far as that goes. Just taking a step back when we do. If it came to an ablation for this stuff, those are usually done in the surgery center, but it's not necessarily because of it has to be done there. A lot of offices don't have that equipment there. But most of the epidurals like this are done in the office itself there. The ones that aren't usually done in the office are what's called the transforaminal injections. And basically, it's just a different name for the epidural. But why it's called that is because it's done where the nerve actually comes out. Now, reasons for this are if you've had significant neck surgery already and your landmarks that we use to do a regular epidural aren't there, or if you've had a regular epidural and it hasn't given you relief. The tough thing here is you have this needle you're putting in here, and there's this nerve, and then you have this nice artery that runs through here, which goes into your spinal cord. So there's a higher chance of having a vascular issue with this. And obviously that's a pretty significant side effect. So these are not done nearly as much as they used to be. A lot of times we will find ways to do the other injection, doing it below the level where someone has had their surgery already, so we can avoid doing this type of injection there. As far as this injection goes, what we're seeing here is the needle is around the actual opening where the nerve comes out, and basically this is just dye that is put into that area is what we're looking for. So injections overall, whether it's the regular epidural or the one around the nerve, questions that I get. So how long will it take to work? Well, that depends on how fast your body breaks down the steroids. Usually it's 7 to 10 days. Everybody's different with that. I have some folks that I see in a follow-up and they come back in and say, I got relief the same day. Now, theoretically, it shouldn't work that way, but everybody's different. And you know, if everybody reacted the same to everything in medicine, med school would be a lot shorter. So, you know, we have to take that into account. How many can you have? Well, two things with this. So say you have no other injections that are steroids, you can have 4 a year. That being said, particularly when I work in an orthopedic practice, you have to keep track of patients' other injections, because it doesn't matter if steroid injection in your knee or a steroid injection in your neck, it's still a steroid. And that's the limiting factor. If we injected no steroid in this injection, you could have as many as you want. You're not going to get much relief, but you could have as many as you want. It's really the steroid part of this that limits the amount that you can have, but it's a total effect. You have to take track. Okay, I had so-and-so injected my knee, so we have to keep that all in mind when we're doing this. How much relief you get? So same answer to everybody. There's no way to know how much relief you'll get, how long it will last, if you'll need more than one, until we actually do it and see how you do. I can't look at your MRI. I can't look at your exam and say, this is how much relief you're going to get. Now, statistically, if you just have a single level where there's a disc and we're treating that, you have a much better chance of getting some relief as opposed to someone who has 4 discs that are all worn out and multiple areas of narrowing around the nerves. And again, they don't change your anatomy. There's no change in the discs or anything to that effect as far as that goes. Myofascial pain. What myofascial pain is when people feel they have the tightness in the muscle and they have areas within that muscle that are called trigger points. A lot of times patients describe pain or stiffness in those areas, and it's usually not localized to just that neck area. Usually it is in multiple areas. It's not radiating anywhere down the arm or leg because it's not a nerve-based cause. Normally no neurologic changes, no weakness or anything like that, but they'll have multiple tender points throughout their body that suggest that this is a myofascial cause to this. And there are folks that just have this. It doesn't have to be a pinched nerve in your neck or your shoulder. You could just be somebody that has this myofascial symptoms. Causes of this, there could be a couple. So the first is when we talk about mechanical reasons. So whether you just started exercising or overly aggressive exercising, if you have joint pain around that area, it can inflame the muscle in that area. Repetitive or overuse of that muscle. Ergonomics, and that's a big thing in the last 20 years as we become more tech-based, whether it's on people on their phone, people on their computer, using a mouse on a regular basis. Any of those things can generate this type of discomfort there. Non-structural causes, anxiety, depression, sleep deprivation, which oftentimes goes with the first two. Are there any chemical or mineral abnormalities that folks may have with this? When you're evaluating someone for myofascial pain and you think this is what's causing them, a lot of times they probably had imaging already that's shown that they don't have a pinched nerve or things like that. But if they're having these multiple trigger points, usually imaging is not indicated. You could do lab work to rule out abnormalities. And sometimes we will have them follow up with a rheumatologist who can do further evaluation of this as well. Treatments for this. Obviously, if it's a mechanical cause, you want to correct the underlying cause, because if you keep trying to treat it and don't correct the cause, then it's not going to get any better. Exercise program is the key for this. to get longer lasting relief. Injections are what we call trigger point injections, which I'll show you in a second. Medications, a lot of medications that are used for this are usually either the antidepressive medicines or anti-anxiety medicines. Sometimes medicines like one is called gabapentin or Neurontin or Lyrica we use that try to help calm down the nerves that go to these muscles there. Obviously, you want to try to correct the underlying cause. So you don't have to have folks on these medications. What a trigger point is basically the center point of that muscle where it's very tight, and you can elicit a response from that with pressure in that area. You can do an injection, and every doctor's a little different. Some will do with just a local anesthetic, I should say, or a steroid-based injection there. Now, the caution with these, particularly when you get in this area in here, is that you don't want to go too deep with the needle, because beneath those muscles is where your lungs are. So the last thing we want to do, again, is create issues outside of what you came in to see us for. And if we give you a puncture in that area, you're not going to be too happy, nor is your primary care physician. So, we take great care in that. We make sure we're pulling back on the needle, not getting any air into the needle and things to that effect there. So a few less common causes of this we'll wrap up with. One is the nerves that come out of your neck. After they come out of your neck, they form kind of like a spider web, like this diagram, and they go down into your arm. And sometimes, in rare cases, you'll have someone will get a viral infection that can irritate these nerves or vaccine that can irritate these nerves. Now, these patients usually have a pretty consistent course. And what I mean by that is they will come in the office, and this is not pain that came about from an injury. They'll come in and just be in terrible pain in this shoulder blade area and in the sometimes into the outer part of their arm, and they're just miserable. And we'll give them medicines to try to help lessen the pain they're having. And then I'll see them in 2 or 3 weeks, and then all of a sudden their pain is gone, but then they have weakness in those muscles, particularly the muscles that kind of bring your arm up and down and in and out there, that are around the shoulder blade area. So it always follows the pain, then the weakness, but treatment for this is conservative. And when folks come in severe pain and I tell them this is what's going to happen and you will get better and it'll get to the point where you're not having discomfort, they often will not believe me, but that's what happens. So sometimes these patients will get an EMG to make sure that that's where this is coming from. But if you have a high suspicion of it, then you treat it conservatively and get them into physical therapy, and ultimately they do really well. Again, not that common, but I just try to touch on a few other things. The next is shingles. And shingles basically is the old chickenpox virus that becomes reactivated, and it tends to follow pathways of nerves. And so for a couple of days before, you may get some numbness or tingling in that area. Then you get the rash. The rash tends to heal within about a month or so. The issue with this is when folks get long-term nerve pain from this, what's called post-herpetic neuralgia, or that PH there. And, that's what becomes the tough part in managing this. Also, again, we're focusing on the shoulder, but if you get the shingles up around the face, that's a whole nother story. The nice thing with this is the vaccine reduces the risk of this from about 50 to 90%. And it's really good, particularly if you've ever seen someone that has it around their face and it affects their vision. That is a life changer for sure, or someone that ends up with this pain on a regular basis from this. Again, the nice thing is the success of the vaccine. Now that I am in the AARP category, I just had to get my first shingles shot. And I will tell you, I've had many vaccines, but that one actually hurts a little bit. But you got to do what you have to do to help with that. The last thing I'm going to talk about is something that's not normally thought of when you come in to see us in the orthopedic office. But again, as I touched on in the beginning of the lecture, something you have to keep in mind. And what I mean by this are somatic causes. And what somatic means is organs within your body that will refer pain to areas where muscles or shoulder or the spinal area is. Because what happens is they share similar nerve areas to those muscles in that area in the spinal column that go to these organs. Most common ones are the gallbladder, which will refer pain to the right shoulder, Your spleen will go to the left shoulder. Stomach areas are typically between the shoulder blades. The cardiac one is a big one between what we call your first and fourth vertebrae and your middle back, as well as your aorta as well between the shoulder blades. We want to keep those in mind. Obviously, those are big things to be aware of. And obviously, with the respiratory and breathing, they can refer to the shoulder blades as well. And why I put this diagram up is this. The way to describe this somatic causes is this cord or this fan, they do different things and they get the same power supply, but they can do different things based on select the way the nerve runs. And that's what you deal with these somatic causes to this pain. So this is just a diagram to kind of show you that, you know, the heart goes up in this area here, gallbladder one side, spleen over here. And so you have to keep that in mind when you're examining a patient. You know, not every patient that's having a heart issue is going to come in with the pain down the arm and sweating and can't breathe and all that. So you have to make sure that you keep that in mind as far as the evaluation goes. My take-home point, regardless of what's causing this discomfort, is the enemy of inflammation is movement. The more you're moving, the better off you're going to be. Because what happens is when you're not moving, whether it's a joint, a muscle, or whatever it might be, inflammation tends to build up. And when inflammation builds up, it limits movement. And when we don't move, you get more inflammation. So you get in this cycle of pain because of that, not moving the joint or the muscle, and that leads to increased discomfort there. Now, again, there are other causes for this type of discomfort. I tried to brush upon the main ones and throw in a few of the obscure there. But I hope I answered some of your questions. And if you have any other questions, I'll be happy to answer them.
Dr. Molter, thank you so much for that. Again, every single lecture that I do with any of our Rothman physicians, I do learn so much. Again, thank you very much for your time this evening. So we have some questions that came in. And the first one is causes and treatment of pain in both sides of my neck when turning head that's worse at night.
So again, something like that, if it's in the neck itself, it usually is one of two causes. And I'm not taking the easy way out by saying I can't tell exactly, but there are two causes that normally would cause, and that's, I know I used cause twice. One would be is if you have wearing down of the disc in the neck. Degenerative disc, unless it's pushing on a nerve significantly, will primarily cause pain in the neck itself. It won't cause pain referring down the arms there. The other would be is those joints that we talk about in the back of the neck, what we call the facet joints there. And a lot of times those joints are involved, particularly in movement or rotation of the neck because of where they sit, and they function in keeping that area stable. So, you know, those would be the two things that you're looking for. It'd be less likely to be a disc herniation there, because though nothing in medicine's 100%, most of the time, if you have a disc herniation, whether it's in the neck or the lower back, it's usually much more pain down the arm or leg than localized to the neck itself.
Okay, thank you. This is kind of, I guess, maybe the same kind of question. It's a pain in the back of the neck when moving your head up and down.
So again, it sounds similar in that, you know, it certainly could be a number of different things. Again, less likely to be shoulder because of where it's localized there. The back and forth is also interesting because of, you know, when you bend backwards, you put pressure on the joints between the vertebrae. And then when you bend forward, you're putting pressure on the disc. So this may be a case where you have something that's affecting both, not only the disc itself, but also the joints in the back part of the vertebrae. Again, less likely to be a disc herniation just because of the pain staying localized to the neck as opposed to going down the arm.
Okay. I might be coming to see you for that one. Can you speak to knots in the shoulder or neck area?
Okay. So I get this all the time is patients will come in with what they describe as swelling. And what that usually is, or the knots that you're describing, is usually muscle spasms. And muscle spasms are a direct byproduct of the nerve being irritated. Essentially what it is your body's way of telling you that there's something going on with the nerve there. That's what that is. Now, again, if you have someone that has them all over, then it's less likely to be from the neck or something to that effect. But, when I examine someone and they have that tight muscle right in the back of their neck, that usually indicates that there's a nerve that's being irritated. Nerves, as I mentioned, are funny things in that they can cause a lot of things, but they don't have to cause all of them. And what I mean by that is they can cause stuff down the arm, numbness, tingling, weakness. They can cause pain in the neck or in the muscles in the neck, but they don't have to cause all of those. But the same nerve that goes down your arm and into your two fingers, your thumb and your index finger, is the same one that can cause you that shoulder blade pain. So it doesn't always have to be, a textbook, well, I have this pain down my arm. It could just be that tight muscle in the neck that's causing that as well, or the nerve that's irritated that's causing that tight muscle as far as the neck is concerned.
Okay, thank you. When I move my neck back and forth, side to side, the neck cracks and makes a crunching noise. Is that to be concerned of?
So I chuckled a little bit because I get this question probably once or twice a day at least. And before I answer it, I always tell patients, this is where I become the big disappointment for you, in that there's no way to know what is making that noise.
Sure.
There is no test to know what is doing that. We have suspicions of when people feel popping, it's maybe those joints between the vertebrae, that there's air in those joints and it's creating that noise there. But we don't know for sure. And there's really no way to know. You could do an MRI, a CAT scan, any test you want, but that's not going to tell you what it is there. Okay. Most of the time it's not something to be concerned about as far as that goes. It's just people hear it or crunching or snapping, and I'm like, I can't tell you what it is. And that's kind of where you have to take the exam into account, look at their x-rays, make sure the x-rays are stable and there's nothing moving around when you're bending the neck back and forth. Other than that, there's not a whole lot to tell you as far as diagnosing that goes.
Gotcha. Thank you. Can nerve pain from your neck cause mild headaches?
Yes.
Okay.
Typically, it would be the nerves in the upper part of your neck. They're basically different types of headaches you can get. Again, that's something that's basically its own topic there. The two most common ones I'll touch on, one is what's called an occipital headache, which is the nerves that come out from behind you, where your head and neck come together. They come up about around the back of your head, along the side of your head. Those are very commonly a cause of that. And usually treatment for that is therapy or doing injections right where those nerves come out. The other is what's called a cervicogenic headache. And what that is a big long name for a cervical spine headache. And what we found that causes most of those is irritation in those joints between the vertebrae. And treatment for that is usually injections into those joints there.
Okay. I've been told 20 years ago I have arthritis in my neck. I have pain and trouble turning my neck at times. Is there anything I can do?
So if we've had no treatments, then that's easy, because the treatment there basically falls under a conservative standpoint, because again, and I'm not a surgeon, but I can tell you that surgery doesn't help neck pain. So surgery is not anything you ever really need to worry about as far as that's concerned. And it's never too late to work on improving the motion or improving the strength in the muscles in your neck to be preventative for not only down the road, but to help with what's going on now. A lot of times, again, basically it's therapy that is done first. And then if that's no better, we do imaging. So say, just for example, you came into the office, we looked at the x-ray, it showed that you had arthritis in your neck. And so our first step, if your nerve function is fine, is normally going to be either to give you exercises to do on your own or to go to therapy. And the reason is because if you've not had any conservative care, that's always where we're going to start. Again, mainly because it's preventative. We see you back in 4 to 6 weeks, things haven't gotten better, then you do additional imaging, normally an MRI, unless the patient can't have that. Once you have that MRI, that gives you a better idea of, if things haven't gotten better, where you need to address things, whether it's between the joints in the vertebrae or a degenerative disc, or is there a pinched nerve that's causing that. But having not had any treatment, the treatment is usually conservative with therapy or exercise to start.
Okay, thank you. What do you suggest for neck pain caused by using my computer and spending time looking down too long? If the screen is raised to even eye to screen level and the pain does not go away, what should be done first?
So a lot of times what not only it's just the screen, but it's also the use of the mouse that can affect things, because folks don't realize it. But when you use a mouse, even just moving it a little bit back and forth, not even big movements, that will engage the muscles in the back of your neck and your shoulder. So, you want to adjust that as well. A lot of times in these folks, if I have someone that's what's generating their symptoms, I will have them take a photo of what they're dealing with, what they're working on, and how they're sitting when they're working on it. And when they go to the therapist, they can help them set that up so it's ergonomically better there. So that's what I usually will do in that situation, is we will have them kind of arrange that the best we can. Now, obviously, if we do all that and you're still having issues, then we have to try to manage the symptoms you're having. But initially, if it's okay, I can isolate it to when I'm sitting at my desk, and this is what we've done so far, then other options include adjusting the mouse versus getting your setup, taking a picture with you to therapy, and let them take a look at it.
Something we all should do.
Yes.
Besides pain in my neck when turning the head, I began having a numb, tingling, painful area in the back of my head, more to the right side. It has increased over the past few months and a bigger area.
So that sounds like it's cut the nerve, that occipital nerve that I had mentioned, that's coming out from the neck and kind of going up into the back of the head, particularly if you're getting numbness and stuff in that area. The cervicogenic headaches, which are caused by those joints there, usually don't cause numbness in that area. They usually more of just a headache kind of thing. When you talk about the numbness itself, a lot of times it's that specific nerve compression of that occipital nerve that we talk about there.
Okay, thank you. What if I get a first epidural and it doesn't provide relief? Do I get another one? I've heard the second one could be beneficial.
Great question. So what we used to do a long time ago was we did a series of 3 on everybody.
Okay.
And we did a month apart, and we saw how you did and came back after that. Well, we found that wasn't the best way to do things, and the insurances really didn't want you doing it that way anyway. So what we do now with the epidurals is we do when you get scheduled for the injection, basically you will have a follow-up to come in about 3 or 4 weeks after that injection. And we kind of gauge how you did there. Now, there's no set guidelines, but the policy is, to me, is if we do one and it doesn't give you relief, sometimes it will take a second one. If we do 2 and it doesn't help, we're not doing a third, because we don't want to keep just putting a steroid in there, but B, a needle in that area if it's not helping. We're looking for some improvement. So if you had a second one and got some relief, but then it came back, then we certainly would entertain doing a third. But normally, if folks have had 2 without relief, then we're not doing a third. The other thing I would say is if someone's had 2 injections somewhere else and then they come and see us, we're not going to do a third just to see if it helps or not, because the reality of it is the epidural is the epidural, whether I'm doing it or someone else is doing it. So if you've had them already and they haven't helped, there's not a reason for me to go and repeat it unless your symptoms have changed there.
Thank you. I think the last question is, will I feel immediate relief from a radiofrequency ablation?
No. What I tell patients this, and I always make sure I tell them this, because I invariably know what happens is they call us a few days after and say, I had this done, it didn't help. And the reason is because when you do that procedure, there's a certain amount of inflammation that is generated just from the procedure itself there. Now, I want to just talk about it real quick. When you have the ablation, there's not a whole lot different from having that versus the nerve injection there. Really, the only difference is instead of having a needle where we inject medicine in, instead of medication, we put a probe through that needle that goes to where the muscle, or through the probe goes through the needle into that area where the nerve is there. So it's not a whole lot different. It's a little more irritating than the nerve block. So a lot of times if it's done at a surgery center, I do recommend patients have sedation for it if you're able to, because it can make it a little more comfortable for you. But, the difference is those nerve blocks give people pretty instantaneous relief, whereas the ablation takes some time. So I always try to emphasize to them that it's not going to work right away.
Okay, we had 2 more questions pop up. Do you want to answer them, or should?
Sure.
Okay. Real quickly, is if you have arthritis in the neck, does application of heat or cold help with stiffness and pain?
Alternate.
Yep. So true. Last one is head, ear, neck, shoulder, and arm pain. MRI and X-ray done that shows inflammation of 3, 4, 5, 6, and EMG shows issues at C6 and C7. Any suggestions? I think that's
So, a couple things. The first is face is not usually from the neck unless it's higher up, way up high in the neck, because sensation in our face tends to come from what we call our cranial nerves, which come from our brainstem. So that's the first thing I would say, that a lot of facial stuff, when patients come in with it, unless it's the high up C2, C3, which is not that common, I would not expect that, and normally have them see their primary or a neurologist for that, because that may need further evaluation there. As far as other management goes, it really depends on what's been done already. If you've had therapy already, then you look at injections versus medication. Again, a lot of times, though, it's a patient preference. We will try medication first before we do injections in the neck. And that's just because it's a neck injection there. But I always tell patients this is not, you have to do this or you have to do that. This is what we have. These are your options, and we can go a number of different ways as far as that's concerned there in regards to that. But again, normally it's therapy first. If you've done that, and it sounds like with that kind of workup, you probably had some other treatments already, then you're looking at either medications or injections there. Most likely an epidural injection, but again, I would say that it's most likely to help with the neck stuff and probably not as much the ear stuff and other things, because you would probably want to get that looked at further.
Dr. Molter, thank you so much. And thank you for all the wonderful questions that came in from our attendees. We greatly appreciate it. I know this was great information for all of us to learn. I know so many of us suffer from this kind of problems every day. So we thank you for joining us this evening. This recording will be sent out to you in a few days. And if you have any further questions for Dr. Molter, please email me at melanie.ionase@rothmanortho.com, which I included in the chat, as well as calling 1-800-321-9999 if we can assist you with making an appointment. So thank you so much, Dr. Molter.
No, thank you to everybody. I appreciate it. As I said in the beginning, I appreciate everybody's support. I've been in that office forever. And, I know people can go other places, so I appreciate you coming and seeing us. So,
Awesome.
all right.
Thank you, everybody, for attending. We appreciate it.
Thank you.
All right. Have a good one.
You too. Thank you very much. Appreciate it.
All right. Bye-bye.
Bye now.